I was originally supposed to just make a few comments after dinner. What I'm supposed to be doing is setting up the panel discussion. And to start the process of thinking about what are the challenges for scientists and for science of this call for global malaria eradication. So as a scientist myself, I have a hypothesis, and my hypothesis is that the critical challenge we face is how to find a way to bridge the gap between the amazing science that you've heard described here moments ago and all through this day, and actual impact in terms of saving lives and reducing transmission of malaria. So I'm just going to add some comments that will help you start on that process. Okay? I don't expect or imagine that I can completely bridge the gap here. I just want to seed the panel discussion. We actually need to start with some definitions. Malaria control is typically defined in terms of reducing the disease burden to a level where it's no longer a major public health problem. That means that people are still infected, as Joe Vinetz pointed out. There are still lots of people infected, but they're not actually sick, or at least if they're sick, they're not terribly sick, and they're not dying. Elimination is a term that applies to a locale, to an area, and it means reducing or interrupting the local transmission so that you have 0 incidence of locally acquired cases. A malaria-free area is an area where there is no ongoing local mosquito-borne malaria transmission, and eradication is permanent reduction to 0 of the worldwide incidence of infection. So there are no more human beings carrying parasites. Someone, maybe Tom McLean, made reference to the Rollback Malaria Partnership, which is a global body. It is hosted by the World Health Organization, but it is outside that body, and it is meant to bring together all of the very, 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 let me underscore, very many parties that have to work together if we're going to achieve eradication eventually. So this partnership brings people together, and they have collectively come up with a global malaria action plan. The thing that I guess I would like to take from this is that their vision of eradication is a progressive one that starts with control, moves toward elimination, and then considers eradication to be a natural extension of local control and local elimination. That is not a universally accepted premise. There are other people who would say that eradication is fundamentally different than control, that all of the economic and social and infrastructural requirements for eradication, in fact, contradict control. So I'm just noting for the record that this is a conversation that's passionate as we go on now. But for this purpose, they envision a stepwise process where we'll gradually achieve eradication. We have in the US the capacity to manage introductions, fair and square. We do this. We still have them all the time. Other countries are not able to manage reintroductions and travelers. You have to have health systems. You have to have political will. You have to have good governance. You have to have actual stable governments. This is one criterion for this moving from this stage to this. Slide positivity rate, less than 5% in fever cases. Before you're even ready to contemplate moving, you have to get that much control, according to this line of reasoning. Here you have to have fewer than 1 case for every 1,000 people at risk. Here you have 0 locally acquired cases. These definitions are very much the subject of discussion and not at all well established. This is a slide from the Malaria Eradication Group. The Global Health Group is at the University of California in San Francisco, led by Richard Feachin. He has convened a group of people to contemplate how exactly would we, as a globe, go about eradication, and they have this this progression. First, aggressive control in what they call the heartland, and I'll show you that in a second. Then progressive elimination from the endemic margins to shrink the malaria map. And the third element is research to bring forward a vaccine, better drugs, diagnostics, and of course, I would say vector control tools. Shrinking the map is one of 2 main strategies that are under discussion. All right, just under discussion. I don't think anyone has a grip. Shrinking the map means progressive elimination of malaria from its natural margins. It means that we begin with an early focus on countries that have low burden. Right now we have active conversations underway in Vanuatu and many of the small island countries of the Pacific. In the SADC is Southern African Development Consortium. 12 countries at the very extreme south of Africa comprise the SADC group. It's an economic group, like we have NAFTA in this country, in the northern hemisphere of the Americas. The SADC countries, 6 of them have elected to go for elimination. There are several Middle Eastern countries. Astonishingly, Iraq is on the list to go for going for eradication. But most of sub-Saharan Africa is generally considered, let me just underscore, generally considered to be not quite ready for this. And here's a set of slides that Richard Feacham presented at the foundation, and which I have borrowed with his permission, just to show you what shrinking the map means. Here's the status country by country of the malaria burden. Red is a country that has malaria. Green, of course, does not. Here's 1900, 1945, 1970, 1990, 2008. Here's what he envisions for 2015, according to the plan he's put forward, and 2025. They haven't actually projected plausibly beyond that. This is something that's underway. There are probably 20 countries in the world that are having these conversations today about how to move toward elimination. General status report, 2 papers that appeared in the last month in the Lancet report on the Gambia and Kenya. They show that the malaria burden is already declining. There are many articles I could put up, but the most recent data show a very encouraging drop in transmission of disease and in burden of disease. The most recent report of the WHO, which was just, I guess maybe it was October or September of this year, reports the same thing. They report 250 million cases a year, down from 500 million. And don't quote me on the 750, it might be 800, but 800,000 instead of 1 to 1.5 million deaths. We're making progress. I think that we have been very conservative in our estimates of how much impact we can have with today's tools. We can have much better impact, but at the same time, of course, significant challenges remain. Not least of which is how you would measure progress. Here, there are many different competing methodologies for estimating the incidence and disease burden of malaria. Any of them has weaknesses, and I guess the main thing that I would like to just get from this is that there are different approaches and there's lively discussion. Collecting data in some of the poorest and hardest hit countries can be a challenge in itself. Just having data about anything, about births and deaths, much less about reliable data about malaria and whether malaria is in fact responsible for a death or for disease or whether it's just a co-infection. Taken together, this is what I took as my assignment to identify challenges. This makes us the first challenge. How would you know if your vaccine or if your transgenic mosquitoes or your house things were working if in fact it's so hard to measure? Secondly, funding. The 2007 total implementation expenditures up to $1.5 billion. Most of it is provided by global donors, although a wonderfully encouraging amount is provided by malaria endemic countries themselves, and then private households have a small consideration. This tells you where those donors, global donors, come from. Most of it is through the Global Fund for AIDS, TB, and malaria. USAID, through its President's Malaria Initiative, contributes a significant amount. The World Bank is here. Look at the US government is responsible by one means or another for over 40% of the funds that go to malaria control. The short answer is that we have a new administration whose commitment to global health we have to wait and see. And we have problems now with the economic downturn. So I would say this is not a given that we're going to be able to sustain this. Here's a timeline showing the Implementation funding, okay, 2003, 2004, it's been growing. Yes, we're making progress. This is why we're making progress. But look, these funds right here have not yet been contributed. These are very uncertain. These were considered in October of 2007, a year ago, to be probable. Now even that's doubtful. So I think I'm going to get to my second challenge. How would you test a new intervention, a new tool, a new strategy? Right now, testing takes place within the context of functioning disease control programs. And that's the good and right thing because we want to strengthen them, not detract from them. But having said so, if they are imperiled, so will be the efforts to develop new tools. This is, to me, what something that I think is the good news, is that this complex life cycle, you've seen so many of them, this complex life cycle gives us many points of entry. You know, we don't have to rely on a single intervention to solve the problem. We've heard about smallpox eradication. There was extremely good news. A vaccine did the job. That was a silver bullet. For polio eradication, we're having a horrible time. And in fact, by many measures, we're backsliding in some areas of the world. The problem with polio is that we've been attempting to use oral polio vaccine with it's a tetravalent with multiple serotypes, multiple virus types. And in fact, the interference among virus types is causing all kinds of problems, is the short answer. We're having to backstop with monovalent oral and injectable vaccines to try and solve the problem. Because we have a single, this is now my personal opinion, because we have a single intervention for polio, we're not making the progress that we would like to see. Instead, for malaria, we have all kinds of opportunities. We can reduce the vector population. Tony was mentioning that, population reduction. We can prevent the development of the parasite inside the mosquito. Okay? We can prevent contact of the mosquito with the human. All of these are vector-directed interventions, and right now we have 3: long-lasting nets, indoor residual spray, and in some places larvicides. We also have drugs that can prevent infection or prevent disease or death. In the preventive approach, we have intermittent preventive therapy of malaria that's just drug provided to mothers and small children at regular intervals, regardless of their infection status. And this has a tremendous impact on their health and on transmission rates. We also have, of course, therapeutic drugs. The new artemisinin combination therapies, ACTs, are largely effective. There's worrying data from the Thai-Cambodia border about tolerance, as someone pointed out. It's also not at all clear what is the implication for selection of resistance of combination drugs. Some people say that although resistance to individual components of a combination drug will be slow to develop, that the time to developing multiple resistance to the whole set of drugs in the cocktail will be no different if the drugs are distributed, individually or in a combination form. I don't actually know that. One of the speakers today pointed out that eventually resistance even to combination drugs is likely to be a problem. So we have many tools, not nearly enough, and we have many points of intervention. Here you have individual countries that are using ACTs, using ITNs together with ACTs, IRS alone, different combinations, and they're able to work backwards to figure out the cost per DALY. A DALY is a disability adjusted life year. Is that a familiar term? It's a way of measuring a complex mixture of morbidity and mortality so that you can sort of estimate the total burden of disease. Vector control is in the neighborhood of $20 to $30 per DALY. As it's presently applied, Nguyen Yan pointed out that it may be possible to target that instead of having to either give a net to every single human being or spray every single house, instead to identify the areas where the mosquitoes are most abundant. Even with these numbers, the estimate is that the world would have to spend $7 billion a year in 2006 dollars to just get universal coverage, hit our coverage targets with the tools we have today. That's not eradication, that's control. $7 billion a year, every year, from now into eternity, to control malaria. So it sort of makes the economic argument for malaria eradication, if nothing else. But here's challenge number 3, that any new tool or strategy has to be cost-effective and affordable. There's also an issue about coverage. On this one, the relative scale of prevention, the estimated number of people at risk covered by either IRS or ITNs, and it increases. What you see is that there's a broad range here of coverage even with the tools that are available. That this coverage is further compromised by compliance issues. Several people, was it Guyan who mentioned that ITNs can be hot? IRS, Joe Vanetz pointed out the IRS, the sprayers are very intimidating. Sometimes people refuse to have their houses sprayed. There are people who are unable to get to a clinic to get treatment, or who have so little money that they prefer to spend 50 cents on chloroquine or a sulfadox SP instead of having to spend the $4 or $5 that they would have to spend on an ACT. So coverage is not the same as actual use. This is people in net-owning households who actually sleep under a net. In Nigeria, 40%. So this is not the whole population, many of whom don't have nets. It's if they actually own the net, did they sleep under it last night? In Senegal, it's up to 60%. But the highest is in Ghana, in the neighborhood of 70%. I was in one country where the lady who's responsible for the bed net distribution campaign, upon going out into the rural areas to distribute them and to oversee the bed net distribution campaign, refused herself to sleep under a net because it was so uncomfortable. Sort of, oh my goodness. Challenge number 4. What level of coverage do we actually need to achieve? Unknown. And how can user acceptability be factored into the design of any new intervention from the start? This is the same basic point that I was making before, and that is that the vectors are very much abundant and diverse. This shows you the dominant vector species by geography. Of 70 anopheline species, 12 of them are considered to be critical for malaria control, given their impact on overall burden. And here is just a map that shows you roughly the distribution of different species. They can be, this was an early attempt that we made at the foundation to try and come to grips with this problem. So I put it out there with a little bit of humility, and I invite you to help me think through what's a way to deal with this. But you could organize them into categories according to when and where they bite. Do they bite indoors or outdoors? Do they bite early or late? If you think about it, a mosquito net would be highly effective against an indoor late-biting mosquito vector. If it's going to be biting you at night during the time when you would be asleep, then you'll be under the net while you're asleep, and you might expect to have pretty good impact. We have these models, control models, that we've started to think in terms of, but we still have tremendous caveats. Specifically, what would you do with some of these secondary species, and how do you trade off the complexity of having multiple interventions, or either globally or within an individual country, and the extra difficulties it creates for implementation. So this is just a way of thinking, boiled down to challenge number 5. How will you find a way to make your interventions, even vaccines and drugs, how will you make them fit the local ecological setting so that they are most efficient? It's not so much the context as the source, a description of the kind of funding and distribution that there is. This is a graph that shows the malaria research and development investment. Unfortunately, it's $2004. It's substantially better than that, but the distribution hasn't changed. Here are the different categories of research. The vast majority goes into drugs and vaccines, which are the big ticket items. The top 5 donors contribute 75% of the total expenditure, and here, so the top 5 donors, NIH, what's going to happen to its budget now? How about us? We're hoping to hold the line in drug and, well, commercial partners. The U.S. Department of Defense, has been pretty well threatened, and the Wellcome Trust. The point of this slide is just that we all have to work together. There are lots of little lines and dots on this graph, and we have to work together, and we have to just remain and renew our commitment to continue with this work. So I'll stop there. Thank you very much.